Okay, your quiz ends at 11:59 p.m. tomorrow night. Okay, I think I have it set so that after it ends, you can review all the questions, but I'm not sure how that works because I haven't done it yet. So if I were you, I would be writing down the questions as I go through, right? Okay, let's talk about what your test is going to cover, and then we'll get into today's material, okay? Here's what your test is going to cover. You ready? Everything in the brain notes after blood-brain barrier, right? Because that was like meninges and cerebrospinal fluid, blood-brain barrier. That was all in the first test, yes? So pretty much all the brain structures, all the real structures and functions of the brain. And then the last set of nervous system notes, which was spinal cord, spinal nerves, and autonomic nervous system. Good. And then heart. And then as far as we got in vessels today was Roman numerals 1 and 2, but not 3. Okay? Which is okay because you're going to be doing 3 in lab this week. Some of you guys did it last week, but there's some people who did it last week. But at least you'll have time to cover it in lab. So the stuff that's in Roman numeral 3 will get rolled over to the fourth test. Okay? All right. So, everybody clear on that? It's a big honkin' test. You should have done a hell of a lot of studying by now. And if you haven't, you've got a really busy couple days in front of you. Okay? Because all of the brain structures and then all of the spinal cord, spinal nerve structures, all of that stuff, and all of the muscles that they innervate, cranial nerve functions, all of that is on this one. We've had a while, so I'm hoping that you're ready. Okay? All right, it's not the easiest test you're going to take this semester, FYI. Okay. What we're going to do now is just look at arteries and the types of arteries that exist, capillaries, the types of capillaries that exist, and then the types of veins. And then we'll get into specific circulatory patterns. Okay? So specifically what we started on last time was we were talking about a little bit about the difference between arteries and veins. Now, arteries tend to have a thicker wall, but which has a larger lumen? Veins or arteries? Veins generally have a larger lumen. Yes. Okay. And that means the pressure is going to be lower, of course, and they're going to be slower flow through veins than arteries. So what we're going to do now is we're going to look at the types of arteries that exist as we go away from the heart. So arteries, of course, have 2 primary characteristics. They're elastic because they have all of that elasticity in their wall, and they also have a lot of muscle in their wall, so they also have the capacity for contractility, or at least structural stability. Even if you're not contracting, you still are like bracing yourself for the blood flow that's coming. So the one thing that I want to tell you about arteries that we see pretty commonly that's actually evolved is that, so if you look at arterial flow to a capillary bed, this would be hard to survive. If I had one artery going to a super valuable capillary bed, right, and I got a blockage, you'd be dead, right, if that was going to your brain. So what often happens in both arteries and veins is that you have some redundancy in circulatory patterns, right? This is called collateral circulation or redundant circulation patterns. And in addition to that, you also have vessels that allow for alternate routes of circulation. So for instance, if this one got blocked, I don't reduce blood flow by half, right? I reduce it, but not by half because I have alternate routes of circulation. So this part right here is called an anastomosis. Anastomoses is plural. And this circulatory, this sort of redundant and alternate circulation pattern is called collateral circulation. And you run into that quite often. Okay, so now let's look at the types of arteries that exist. So basically, as we go away from the heart, here's the general pattern. As you go away from the heart, of course, the arteries get smaller until you get to arterioles, right? But then in addition, they also have sort of different needs. When you're really, really close to the heart, like the aorta, you need far more elasticity than contraction. Does that make sense? You really don't want to contract the aorta, do you? No, you do not. Now, the muscle in the wall, there's a bunch of it in the wall of the aorta, but it's primarily for structural stability, not for contraction. So the arteries that are super close to the heart are considered elastic arteries because that's their primary characteristic. The aorta is a classic example of an elastic artery. So is the pulmonary trunk, but we're not really talking about pulmonary circulation right now. So the aorta, classic elastic artery. And then as we move away, the vast majority of arteries that you are going to run into are called muscular arteries. Not because they don't have any elasticity, but because the muscularity tends to be a little more important than the elasticity as you leave the heart, right? As you get further away. So they're a little bit wigglier, a little bit more likely to do vasoconstriction, and have a little less elasticity because they're not receiving blood in big squirts as much. Okay, so classic examples of those would be almost every artery that you're going to learn this week or you learned last week. Like the brachial artery and the femoral artery, those are all muscular arteries. Is that okay? Okay. And then as you move further away, you get down to the ones that are like 0.3 of a millimeter, too damn small to see or label. And they're too variable from person to person to label either. Those are called arterioles. And arterioles don't need to be very elastic, but they're super wiggly. They are actually what controls blood flow patterns to what? Arterioles control flow to what? What comes after an arteriole? Capillaries. So they're really, really active in vasoconstriction and vasodilation. So if a tiger walked into the room, what would happen is I would want to dilate the arterioles leading to my brain, heart, lungs, and skeletal muscle capillaries, right? But then I would want to constrict all of the other arterioles. That makes sense? So arterioles are really kind of the gatekeepers to capillary beds, and so they're really like wiggly. Do a lot of vasoconstriction and vasodilation, okay? Now, those are too variable to name individually. Nobody knows the names of them individually. In addition, they're really difficult to see. Arterioles, of course, will lead to capillaries, and capillaries are the simplest in structure. We already talked about their structure. They're just a single layer of simple squamous epithelium with a basement membrane underneath it. And so capillaries, this is a systemic capillary bed. So it has an arterial end and a venous end. Logic question, I'm sure you can figure out the answer to. Which end, arterial or venous, is higher pressure in a capillary bed? Arterial, exactly. And it's for a couple of reasons. One of them, which is like immediately logical. It's closer to the pump, right? Right? And the other one that may not be immediately logical, as you go through a capillary bed, the capillary is porous and high pressure, and the interstitial fluid is low pressure. So you do filtration and lose fluid as you go through a capillary bed. Less fluid in tubes means lower pressure, correct? So that, in addition, is going to make the venous end of a capillary bed lower pressure. Is that okay? Okay. So what we're going to do is, as we go through a capillary bed, we push out fluid by filtration. We gather up the vast majority of it by osmosis, push it out by filtration, gather it back up by osmosis. Why the heck do you care? Well, that means I'm getting fresh interstitial fluid all the time, right? It means I'm actually having turnover of interstitial fluid, which is good because that's the fluid that's actually bathing the cells in there. Okay, so that is your capillaries. So we did elastic, muscular, and arterioles and capillaries. Okay, so now let's look at the structure of a capillary and the types of capillaries. So capillaries are super duper branched. This isn't even showing how branched they actually are. But what we're going to look at is the reason capillaries are highly branched and super thin is because, of course, they are the locations for gas exchange, right? And so the vast majority of the 60,000 miles of blood vessels that you have is made of capillaries. So I want to show you a couple of different ways that capillaries can actually serve you. First off, let's imagine that this is a capillary bed. Damn it, why won't you open? This is a capillary. Hold on. It's being annoying. This is a capillary bed that's running through a uterus. I can't do it. This is a capillary bed that's running through a uterus, okay? So I've got the arterial end and the venous end. So let's look at picture A first, okay? The blood is percolating through the wall of the uterus, right? And then a tiger walks into the room. Do I want that blood to fart around in the wall of the uterus when there's a tiger in the room? No, you need to get it all the way back into circulation as quickly as possible. So although capillaries do not have smooth muscle in their walls, what they do have is little smooth muscle cuffs at little junctions in the capillary. So what happens is this is no tiger in the room in the wall of the uterus. This is tiger in the room in the wall of the uterus. Do you see what happens? What happens is you can shut down what are called precapillary sphincters and force blood to go quickly through what we call a thoroughfare channel so that you can get it back into circulation. Does that make sense? And are the precapillary sphincters at the arterial end or the venous end? Arterial end, right? So you're like, we have got places for this blood to be. So you shut down the blood flow, force it through the thoroughfare channel and back into circulation. Okay? So this is precapillary sphincters forcing it through blood flow quickly. Okay, so now let's talk about the types of capillaries that exist because they're not all the same. So capillaries are all simple squamous epithelium with a basement membrane in between, but they have levels of porosity that change. Okay, if you're more porous or holy, not but the other kind of holy, if you're more holy, you have really good for transport but really crappy for protection, right? If you're not holy at all, you're okay for transport but really, really protective. I mean, it's still thin enough that it does transport, but it's pretty protective. So we've got 3 different categories of capillaries. The first one is called a continuous capillary, and although you can't see it there, I want you to imagine that between every single one of those cells, there are tight junctions. Okay? That means that if anything wants to get from the capillary into the surrounding tissue, it can't go between the cells, it has to go through the cells, right? So you have a lot of control of what is transported in and out of the tissue. I'll bet you can think of a location that you would have these continuous capillaries. The brain, exactly. The brain has continuous capillaries, and actually they're even tighter than these. They're called continuous complete capillaries. They're like, I am not messing around. Nobody's getting through capillaries. Okay. The dermis of the skin has these because you don't want to have a whole lot of water loss on accident. So this is a continuous capillary. This has a lot of control over transport. This one is meant to do transport, so it's a little less controlling, a little bit fewer tight junctions. And in addition, if I looked at one of those cells from the side, so it's a simple squamous epithelial cell, right? So if you look at it from the side, it looks like a fried egg, right? But instead of just being a fried egg, what I have is in certain places, I can push all of the cytoplasm and organelles out of the way. So I've just got 2 layers of plasma membrane, like a double paned window. And doesn't that allow for more transport, right? Those are called fenestrations, and you can see little windows. They're not holes, right? They're double paned windows. They've actually got cell membrane in. So it's not like you're completely losing control, but you're increasing transport. These are called fenestrated capillaries. I have those in locations where I want a lot of transport, still want some control over it. For instance, you find these in the kidney, where you're supposed to do a lot of filtration, right? You also find them in the capillaries that are just deep to the small intestine because you're supposed to do a lot of absorption, okay? So those are fenestrated capillaries. And then these guys right here will just take whole things in and out of the capillary. It doesn't have a complete basement membrane. It's got huge holes between the cells. Big chunks of stuff can get in and out of these. These are called sinusoid capillaries. They are the widest of the capillaries. What will that do to the speed? It's going to slow it down, right? Got the same amount of fluid, make the tube wider. It's actually going to slow it down, right? Unless you increase the amount of fluid. Okay, you're going to slow it down. And they're also super curvy. That will also slow it down. Yes? Okay. They've got big holes. Where do you find those? You find these a couple of places that'll make sense. And the liver is one of them. Okay. So you may or may not have learned this yet. All of the blood that gets absorbed from your digestive tract, which is not sterile. The food that you eat is not sterile. It's got potential pathogens in it all the time. So you are going to absorb that, but before you dump it into circulation, you actually send it through the liver. And as you send it through the liver has these wide sinusoid capillaries. And sitting on the surface of the sinusoid capillaries are these big liver white blood cells called macrophages. And they're actually watching the blood go through. So let's say you had the bad fortune to eat some E. coli tainted spinach. Happens, right? Okay? And so what happens? You absorb it, and then it goes through the liver, and the liver goes, oh, crap, literally. That's where E. coli comes from. So, and what it does is it actually reaches down in and gobbles up and does phagocytosis on anything weird that goes through the liver. So it can take whole cells in and out, right? So that is what is sort of going on with the liver, that big sinusoid capillary. There's another place that you have these sinusoid capillaries. See if you can figure out what's going in and out in this location. You have sinusoid capillaries in red bone marrow. Why have the big holes? What's going in and out? Blood cells. Yes, you are making blood cells. How do you get them in? There's a big freaking hole in the capillary. You just shove them in there, right? Does that make sense? So sinusoid capillaries are where you want to bring whole cells in and out. Cool? Okay. So let's talk about veins a little bit. Veins are going to carry blood back toward the heart. They are also called afferent vessels, and they change as you go from the capillary up. So as you start from the capillary, the littlest veins are too small to label. They're called venules, right? They're about the size of an arteriole. You never have to know them by name. They're just little veins, right? And then you've got medium-sized veins, which would be most of the veins in your body, like the brachial veins and the femoral veins and all of those. Those usually have names. Most of the veins you're going to learn would fit into those. And then you have the big hunkin' veins. And the big hunkin' veins would be pretty close to your heart. Like, give me an example of two of the big systemic veins. Superior and inferior vena cava, right? Does that make sense? So this is the pattern that we have as we go through. You can, of course, see that there's far less smooth muscle in the wall, and they're nowhere near as elastic. Something that you can't see in this figure, but is important, is to know that veins are far more variable than arteries. This is good to know before you start hunting around for them in a cadaver. So why the hell are veins more variable than arteries? Well, think about it this way. Okay, evolutionarily speaking, if I developed a mutation that caused an alternate kind of circuitous route of arterial circulation to my brain, can you see why there would be evolutionary pressure against that? If the blood is not going directly from my heart to my brain and then something chases me, right, I might not survive, correct? So can you see how there's a lot of evolutionary pressure on arteries to get where you're going? Yeah, does that make sense? How about veins? Does it really freaking matter how much you fart around on your way back? It doesn't matter. There's a lot more variation in veins. There are 3 times as many veins as arteries. Because when somebody developed an extra one, evolution was just like, meh. Doesn't make any difference, right? You're just going to like eventually get back to where you're going. Blood is not in a hurry. It's on its way home from work through veins. There's a lot more variation. Now, anatomy students hate this because they're like, the book says you have 2 brachial veins, and this guy has 3. Why? Because veins do whatever the hell they want, right? So how do you know? Well, you just follow it, right? You follow it until you see where it goes, and then you're like, oh, okay, that must be that one, right? And then every once in a while you don't know, which is part of the reason that I like to dissect things, because I like to get confused. I'm like, oh, what the hell's going on? What the hell's going on? And I like that moment before I figure it out, right? Because I'm about to learn something. So a lot more veins than there are arteries, and they're a lot more variable. And because there are 3 times as many, that also drops the pressure, right? If you're going through 1 tube and coming back through 3, can you see how that would actually decrease the pressure? You have the same amount of fluid going to a capillary bed through 1 tube and then coming back through 3, right? You are going to have low pressure in each of the 3, right? So it is going to be far more variable, lower pressure on the way back in veins. Okay, so now, since they are such low pressure, and since there are so many of them, at any given moment, there is generally more blood in your veins than in your arteries. So at any given moment, like right now when you're at rest, about 65% of your blood volume is in your veins. Okay, just farting around on its way back home from work. But if a tiger walked in, what would you do? You would constrict all your veins, dump it back into your heart, and then send it into your arteries and your capillary beds. So it's just kind of like a placeholder, right? Because eventually you might need more blood flow, but you don't need it right now. So it's just sort of on its way back. So super low pressure. How do you get things to go when it's super low pressure? Well, most, but not all veins have valves in them. Arteries don't need valves. Pretty high pressure and pretty straight shot. Veins, many of them, have valves. And what the valves do is the lowest pressure veins that you have are the ones that have to deal with both low pressure, lots of veins, and also gravity. So the places in which veins are most at risk of backflow is in your arms and your legs, okay, especially your legs, okay, because you're going against gravity to get back to your heart, right? Okay, and you're really low pressure. So how do you make blood stay unidirectional when you've got the possibility of backflow? Well, valves help. What you have is these valves that will increase, that will open due to increased pressure on the bottom, but they will close due to increased pressure on the top, right? So the way that I think about blood going through the valves in a vein is like, you know, the up on a roller coaster in which you're like, chook, 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 right? But if you get more active and you contract your skeletal muscles near the veins, can you see that it's going to increase pressure and blood can't go backwards, so it has to actually increase blood forwards, right? So if your skeletal muscles are more active, then you get better what we call venous return through the veins to the heart. Is that okay? So that happens with skeletal muscle contraction. You have valves in your arms and your legs and the veins, not the arteries. But you don't, for some interesting reason, have valves in the veins in your abdominal pelvic cavity. And that's because I have a different mechanism of making sure that I get blood back. And it's this. Okay, here's how I make sure I get blood back through the veins in my abdominal pelvic cavity. Well, I breathe pretty damn regularly, and so do you. And here's how breathing works. I don't know if you learned this anatomy yet, but the superior and inferior vena cava are continuous with one another, correct? And they go through your diaphragm, and they go all the way into your abdominal pelvic cavity. Everybody okay with that? Okay, even if you haven't learned it yet. It's continuous all the way through the diaphragm. So when I breathe, what happens is my diaphragm goes from being bell-shaped, right, to being flat. What does that do to the pressure in the abdominal pelvic cavity? Increase. What does it do to the pressure in the thoracic cavity? Decrease. So every single time I breathe in, I inhale, I increase pressure here and decrease pressure there and squirt blood up those veins, right? And how often do you breathe? All the time. How about when you're exercising? Even more often, right? And even deeper. So you get the best venous return back to your heart when you're exercising because of skeletal muscle contraction and also respiratory contraction. So the skeletal muscle contraction aiding in blood venous return is called the skeletal muscle pump. And then the respiratory system aiding in venous return is called the respiratory pump. Good? And they work at rest, but they work better when you're working out. Good? Okay. So now, sometimes these valves are weak. So if the valves are weak, then what's going to happen is as the blood tries to go backwards, it will sort of pool on top of the valve. And as it pools on top of the valve, if you have a weak connective tissue in the wall of your valve, then it can balloon out, right? And that is actually called a varicose vein. So let me show you what a varicose vein looks like and talk about how you get them. Here's varicose veins, right? What you're seeing is actually ballooning out valves. How do you get these? Well, genetics will help if you've got a genetic predisposition to them. And then there are some other behavioral things that would increase the likelihood of varicose veins. Anything that increases the pressure up here so that it's harder to get blood going this direction. So if you gain a lot of weight, right, you're increasing the pressure that's up here. If you're sitting down a lot, then you're increasing the pressure that's up here, right? If you are standing a lot, right, the blood is trying to pool on top, but not if you're walking a lot. If you're walking a lot, then the venous return helps. Does that make sense? Okay. So varicose veins, genetics, pregnancy will do it. Pregnancy increases a lot of pressure in here. And if you're like one of the, I hate to tell you, but one of the professions that's most likely to get varicose veins are nurses. So if you're a nurse, be a wiggly one. Be the wiggly nurse, right? That gets up and does stuff, not the one that sits or stands around all the time. It's also one of the professions that has the highest incidence of obesity. You don't have to be a fat nurse. You don't have to. Okay. Okay, now it's even worse when you get a varicose vein in the wall of your anal canal. That's called a hemorrhoid. Primarily exacerbated by sitting a lot because I've got blood that's trying to go up and I'm actually increased pressure here. And then pregnancy will get you some hemorrhoids quicker than anything, right? I know it doesn't come out of your butt, even though I thought until it was 12 that it did. But all of this pressure that builds up here will actually cause varicosities in the anal canal and cause hemorrhoids. And you don't even have to be heavy for that to occur. I'm trying to make sure that you guys don't get knocked up on accident, right? You're like, oh my God, hemorrhoids, death, everything. Okay, so that's hemorrhoids. Okay, so there are really big veins with really big lumen size. There are far more big veins called sinuses than there are big arteries. Any idea why there would be more venous sinuses than arterial sinuses? Sinus is just a big open one, big wide one. Why more venous sinuses than arterial sinuses? Yeah, because arteries need to stay high pressure. So you don't have a whole lot of super duper wide arteries, but you have a decent amount of super wide veins. So remember that you've already met some sinuses. You've met the coronary sinus, right? You've met all the dural venous sinuses. So just a big wide vessel is called a sinus, and you're far more likely to run into them in veins than you are arteries. Good? Okay, so now what we are going to do is some circulatory routes. Okay, so I want to teach you guys the way that I think about circulation, because I'm the one who's going to write your test on circulation. So there's a bunch of different ways that you could, for instance, teach circulation. Here's how a lot of people do it, and it bugs me. Okay, I could go through and I could learn all of these arteries, right? And then I could look at a different picture and I could learn all of the veins. But what that doesn't do is just rote memorization. What it doesn't do is to get you thinking about blood flow. What I would prefer is that you could, for instance, get me from the heart to anywhere in the body and then back to the heart, because that's how circulation works, right? So the good student could, for instance, get blood flow to the frontal lobe of the brain and then back to the heart, right? So I want you guys to think about circulatory system routes as not rote memorization, but as patterns, right? So we know that we need to lead to a capillary bed. So arteries are going to supply, and then veins are going to come back from the capillary bed, and veins are going to drain, yes? So instead of, for instance, just saying, okay, this is the subclavian artery, yeah? I want you to tell me which direction blood is flowing through the subclavian artery and where the hell it might be going. Which direction is it flowing? It's going out that way and it's going to the arm, right? That makes sense? And then, for instance, after you got done with that, you could say, okay, this is the right subclavian vein. Which direction is blood going through the subclavian vein? It's going back, right? So I want you guys to think about circulation the entire time instead of just rote memorization. And that's how I'm going to talk about it. So, okay, so let's talk a little bit about circulatory routes. So let's talk about pulmonary circulation first. So when I'm doing pulmonary circulation, I'm using the pulmonary circuit, and I'm getting blood from the heart to what organ? Lungs, and then back to the heart, right? So this is the easiest circulation pattern because it's right next to the heart, right? But you do need to know the big picture. So when we're doing pulmonary circulation, this is putting back together the stuff that we did last time. What chamber are we going to start in with pulmonary circulation? Right ventricle. Yes, we're going to start with the right ventricle. And so if we do pulmonary circulation, we're going to start with the right ventricle. We're going to go to the lungs, and then we're going to go back to what chamber? Left atrium. Okay, so let's learn a few more vessels than you have learned before with pulmonary circulation. So let's start here. Okay, so if I'm doing pulmonary circulation, I am going to go right ventricle through what valve? Right ventricle, be more specific, not just semilunar. Pulmonary semilunar valve into what vessel? Pulmonary trunk, also called the pulmonary artery, but pulmonary trunk is safer because then you're going to split into the left and right pulmonary arteries, yes, that go to the left and right lungs. Now, it's not shown very well on here, but I am going to tell you that the left and right pulmonary arteries will split into lobar arteries that go to each lobe of the lung. Does anybody know how many lobes you have on the right side and left side? 2 on the left and 3 on the right. It's just like the valves of the heart. Try to do right by what's left. So does it surprise you, even though you can't label them in the picture, but conceptually, from the right pulmonary artery, you split into 3 right lobar arteries. Yes? From the left pulmonary artery, you split into 2 left lobar arteries. Good. Just supplying each of the lobes of the lungs. They're not labeled very well there. Supplying each of the lobes of the lungs. And then, of course, we're going to split into smaller arteries. You don't have to know those. And then into arterioles, right? And you don't have to label those individually, but conceptually you understand this, right? And then, of course, we're going to go to capillaries. But the capillaries of the lungs are weird looking, okay? So what we have with the lungs is we have a bunch of microscopic little air sacs called alveoli, and you can see them, those little microscopic air sacs. And they are made of a simple squamous epithelium, one layer, with just a basement membrane in between them. And of course, this is what you are ultimately going to get the air into when you breathe in, this little alveolus, okay? And then on the wall, on the outside of each alveolus, what you're going to have to do is run capillaries by it. So instead of having one big capillary bed, to me, it looks like trillions of little teeny capillary beds, like sort of hugged around each alveolus. Does that make sense? Okay, so here's what's going to happen. The blood that I deliver to my lungs is what oxygen content? Low oxygen content. So if we followed this, this would ultimately be traced back to a pulmonary artery, right? Okay, so now let's follow it as it goes by an alveolus. As it goes by an alveolus, what it's going to do is layer of simple squamous epithelium with the capillary, layer on the alveolus. It's going to go by, and you're going to do gas exchange in which you are dumping carbon dioxide into the alveolus, right? And what are you picking up from the alveolus? Oxygen from the alveolus. And as you do that, you, of course, are going to change the color of the blood to bright red, right? And then it's going to go out the other side. And now this nice oxygenated blood is going to go ultimately into a branch of the pulmonary artery, yeah? And then the pulmonary artery is going to come back to where? It's going to go back to where? Left atrium, exactly. And how many pulmonary arteries do I have usually? Yeah, 2 right, 2 left, right? Back to the left atrium. Does that make sense? Okay, that's pulmonary circulation. Go ahead.
What type of capillaries are fenestrated?
They're actually not fenestrated because you're only dealing with lipid-soluble gases primarily, so it doesn't even matter if they have holes because oxygen is super duper lipid-soluble. So you don't really even have to make holes for it because it just does whatever the hell it wants anyway. And carbon dioxide doesn't have any transport problems either. So they're kind of in between the first 2 types, like some tight junctions, but not a whole lot of fenestrations. Go ahead.
Is there like separate arteries and veins that supply blood to the lungs? Kind of like the heart and the arteries?
This is the ones that supply blood to the lungs. Now, if you're asking, if what you're thinking is, what about the outside of the lungs? Is that what you're thinking?
Yeah.
Okay, that's a good question. They don't ever make you learn these, but that's a great question. So what about the outer portions of the lungs that aren't doing gas exchange? Yeah? They wouldn't need pulmonary blood, they would need what kind? They would need systemic blood, and that actually comes off your descending aorta and gives a little bit of systemic blood to the outer portions of the lungs. That's a good question, but we're not going to do that today. We will do it probably Friday. Good? Everybody okay? Okay, so you got this pattern. It's pretty simple. There aren't very many vessels involved in it. So now what we are going to do is start talking about systemic circulation, okay? So with systemic circulation compared to pulmonary circulation. Oh, I forgot to tell you, we're dealing with pulmonary circulation, and you look at blood pressure. Pulmonary circulation, pulmonary pressure at rest is about 25/10. 25 millimeters of mercury right when the ventricles contract and 10 right before they contract again. So that's how variable it is. But you guys know that systemic arterial circulation at rest tends to be about 120 millimeters of mercury right after ventricular contraction, back down to 80. So you know this, but I want you to put the thoughts together. 2 questions. First, get this one out of the way. Why is it okay to have way lower pressure in pulmonary circulation than systemic? Why is that okay? It's not going very far, exactly. And then the second question, and this is the one that people always misunderstood, but you'll probably get it the first time, and that is, what anatomical difference accounts for the difference in pressure in pulmonary and systemic circulation? Yeah, it's the thickness of the ventricle, right? So the left ventricle works about 3 times as hard as the right ventricle. So it's the thickness that actually accounts for it. Does that make sense? Okay. So what we will see with systemic circulation is with systemic circulation as we look at the arteries in systemic circulation, every single artery in systemic circulation can be traced back to the left ventricle and then comes off of the aorta. Yes? Okay. So the way that we are going to address systemic circulation, we won't get through tons of it today, but the way we're going to address systemic circulation is we're going to give blood to things as they get blood, right? So we'll do the three portions of the aorta in order. What's the first portion of the aorta? Ascending aorta, and then aortic arch, and then descending. So what we are going to do is we're going to deliver blood off the ascending aorta to wherever it goes, and then back to the heart, right? And then we're going to deliver blood off of the aortic arch to wherever it's going, and then back to the heart. And then we'll do descending. Does that make sense? Okay. So everything is ultimately coming from the left ventricle and the aorta. And then you guys know it, but tell me anyway. All of the blood in systemic circulation is ultimately coming back to the heart through three vessels. What are they? Superior vena cava is head and arms. Inferior vena cava is everything below the heart. And one more. Coronary sinus is the heart itself, right? And so we are going to do systemic arterial and systemic venous circulation together. Generally, although not always, if you find an artery and you find the vein running with it, they're named the same things. That's especially true in the arms and the legs. It's really not very true here. Venous pattern is really different in the abdominopelvic cavity. As I mentioned, there are 3 times as many veins as arteries, and many of them are superficial. And veins branch anywhere they damn well please, because there was really no evolutionary pressure against them branching wherever they please. So the unfortunate thing for anatomy students is that means that you have to look at all of the cadavers. But it's not as bad if you remember that you don't name a vein based on how it looks in the picture. You name it based on where it's going, right? So if you've got a brachial artery that's going to here, you get a vein running along with it, and you watch where it dumps. You can say, okay, if this is the one that dumps into the axillary and then the subclavian, I'm going to call this brachial, even if it looks weirder, right? So you do the same thing that you did with the muscles. Instead of memorizing muscles, you actually sort of follow them, right? You follow them and see where they attach. Okay. So the way we are going to talk about arteries is what does the artery supply, and the way that we're going to talk about veins is what does the vein drain. Go ahead.
Are all arteries and veins innervated?
Innervated?
Yeah.
Except capillaries. They are all innervated by the sympathetic nervous system, which can cause vasoconstriction or vasodilation. Capillaries don't have any smooth muscle on the wall, so they're not. Okay? All right. So let's start with systemic regional blood flow. So here's how I think about blood flow patterns. So what we are going to do is we're going to go ascending aorta. What does it give blood to? Anybody know? The heart. Only the heart, right? And then we're going to come back from the heart and deliver it back, right? And then we're going to do the 3 branches off the aortic arch, right? And then we would start. We probably won't get to it today. We'll start descending aorta. Okay, so first thing is you've already done this trace. You already know that the ascending aorta only gives rise to coronary arterial circulation, right? It gives blood to the heart, right? But I want you guys to think about this instead of in rote memorization and identifying vessel on the surface of the heart. Instead of thinking about that way, think about it in a blood trace, okay? So if I asked you, and this is one of the traces that you have to do this week anyway, so do this one first. If I asked you, could you get me blood from the left ventricle to the anterior wall of the left ventricle, from the inside of the left ventricle to the anterior wall of the left ventricle, and then back to the heart? Could you do it? Right? So you would leave, let's just think about this blood trace and do it verbally, okay? From the chamber of the left ventricle, I would leave through what valve? Aortic semilunar valve into the what aorta? Ascending aorta. And then get me into the anterior wall of the left ventricle. Left coronary artery, yes? And then branch onto the anterior wall and go anterior interventricular artery, right? Now you're thinking about blood flow patterns. And I get to the capillary bed, and now I'm going to get back, and I do Great. Cardiac vein into the coronary sinus, back to what chamber? Right atrium. Okay, so expect to have to do that trace because you had to do it for the last set of notes too, right? That makes sense? So that one is good for both heart and vessels, right? You learned it on the heart because that's where you see the vessels, but now we also know conceptually that it's part of systemic circulation, yeah? Systemic arterial and venous circulation. So that's the first blood trace that you did, but it's not going to be the last one that you do. Okay, so we did that, and you guys should be pretty confident with that right now. Most of you guys really seem to be getting the heart. Do you feel like you're getting the heart? It's pretty logical, right? After you spend a little time with it, it sticks pretty well. Okay, so now we are going to do the aortic arch. So I want you guys to understand the aortic arch before we start memorizing it. Okay, in the vast majority of us, the aortic arch arches left. It arches over to the left side, okay? Now, every once in a while, there's somebody who has everything flip-flopped, and we have one of those at the body donor program, which is awesome to see. He's got, it's called situs inversus totalis, and everything in the whole abdominopelvic cavity is flipped left and right, which was interesting because they actually discovered him in med school. So you get into med school and you get a cadaver with like 4 of your med school compatriots, right? And they open him up, and they immediately took that cadaver away from the med school patients because you do not want to have burned into a doctor's brain everything flip-flopped, right? So they went and scooped him up, and then the body donor program directors actually did the dissections, but it's really amazing because you like look at it and it's one of those times in which you're like, I know something's wrong here. Something's very wrong, but it took me a minute to figure it out. An embarrassing minute, actually. Okay, so anyway, it arches left, okay? That means that if I want to give blood supply to the left side of the head and the left arm, I can do it directly from the aortic arch. You guys with me? So I can give blood supply directly to the common carotid, which is going to the head, and the subclavian, which is going to the arm. I can go straight off the aortic arch to do that. Does everybody see that? The left common carotid and the left subclavian go off the aortic arch. But if I want to give blood supply to the right side of the head and the right arm, I need to jog back over to the right side. Do you see that? Okay. That is why on the right side, but not the left, I have one extra artery that I have to learn in the circulatory system pattern. So here I go aortic arch directly to left common carotid. Here I go aortic arch, jog over to the right side. That's called the brachiocephalic artery or brachiocephalic trunk sometimes, okay? Jogging over to the right side. And then I split off into the common carotid and subclavian. Does that make sense? So when you're doing right head or right arm, you have one extra vessel, okay? Because you got to get over there. Is that okay? But the good thing is that after you got over there, it's the same. After you get into the common carotid, the blood flow pattern is the same. After you get into the subclavian, the blood flow pattern is the same. Is that okay? Okay. All right, so let's talk about that. So the aortic arch has 3 major branches in order that they get blood. There is brachiocephalic, right? And then left common carotid and left subclavian. Good? Okay, we do have one cadaver, however, on Redwood campus that has 4 branches off his aortic arch, just to confuse the living hell out of me. It was cool, though. I finally figured out what it was. I'll tell you what it is in a minute. Okay, I had to like dig around. I was like, what is that doing and where is this applying? Okay, so the brachiocephalic artery or brachiocephalic trunk gives rise to the right common carotid and the right subclavian arteries. And then the left common carotid and the left subclavian come directly off of the aortic arch. So let's deliver blood to the first things that get blood. What do you see? First getting blood off of the aortic arch. Head, yes. First dibs after you did the heart, which was off the ascending aorta, but first dibs off of the aortic arch is head, okay? So what we are going to do is we are going to deliver blood to the head, so arterial blood supply to the head. The vast majority of blood supply to the head and the neck is from the left and right common carotid arteries. And you know carotids because, of course, you learned the holes that one of them goes through, right? It's going to go through the carotid canal. Okay, but FYI, if you have a common vessel, it means it's going to split. And it's usually going to split into something that's named similarly. It's usually either going to split into a superficial and a deep or an internal and an external. So in this situation, your common carotids go up here, and that's where you can feel your pulse in your neck. You can feel the common carotids. And they actually divide at a wide open space right there. Do you see this wide open space right here? It's a little wide for an artery. Let's look at it from the side. Okay. Do you see this right here? That's called the carotid sinus, right where the internal and the external divide. Is that okay? Okay. So the common carotid is going to go up, and then right about here, right about on top of the thyroid, I'm sorry, on top of the larynx, it'll divide into the internal carotid, which goes inside your head through the carotid canal, and the external carotid, which goes outside your head. So how do you tell which one's internal and external? Don't memorize them at the branch points, because those little buggers will twist however the hell they want, right? You follow them, right? You follow them to see if it ends up outside the head or inside the head. Does that make sense? So the external carotid will supply the outside of the head and the skull, right? Make sense? And the internal carotid will supply the inside of the head and, importantly, the brain. So the internal carotid arteries are going to supply the brain. So follow this in. It would go through the carotid canal, and then let's see how the brain is actually supplied. Okay, so if we look at this from the bottom and we look at how blood is actually getting to the brain, we will see this. Okay, here's the brain. Here's the ventral surface of the brain. Notice right near the pituitary gland right there. Those are two cut-off vessels that you can see. Those are your two internal carotid arteries, and they come up right near the hypothalamus and the pituitary gland. Those two, the left and right internal carotid arteries, supply 75% of the blood supply to the brain. Pretty damn important. Okay, but please note that there's a circular pattern, right? This is the cerebral arterial circle right here, because if, for instance, I got a blockage right here in this artery, do I just say it was a nice run, I'm done, right? No, I actually have collateral circulation. I go around and get the blood from another way. Does that make sense? Okay, so I got 75% of the blood supply to the brain, but what about the other 25% of the blood supply to the brain? The other 25% of the blood supply to the brain actually comes off of here. So stick with me for a second. Okay, so watch. Here is the common carotid. This is on the right side, so you're at brachiocephalic and then common carotid. If you were on the left side, you would be directly off of the aortic arch to common carotid. Good? So here's brachiocephalic and then common carotid. Internal carotid at 75%. Now let's get the other 25%. The other 25% comes off of the subclavian artery, and it goes up through the transverse foramina of the cervical vertebra. Remember the transverse foramina? Okay. Both transverse foramina, and then what it will do is they will come together anterior to the medulla oblongata, go up the foramen magnum to the brain. Does that make sense? Those two are called the vertebral arteries because they run up the holes in the vertebra. Good? Okay, so let me show you that here. Now, so we've got internal carotid 75%, vertebrals 25%. Here's the vertebrals on this picture, right? Do you see them? Two vertebrals, which will then come together and form this vessel right here. This is called the basilar artery that runs up the cleavage of the pons, right between the halves of the pons. And then notice that this actually forms a circle. Good? Okay, last thing that we're going to do, don't wiggle until we do it, is we're going to deliver blood back from the brain back to the heart. Cool? Okay, so how are we going to get blood back from the brain back to the heart? We are going to go through jugular veins, right? Okay, so let's talk about this one for a second. Okay, the vast majority of the blood that was in the brain comes back from the brain. Remember your dural venous sinuses? You learned all of those already? All of the dural venous sinuses are ultimately going to dump into the internal jugular vein. And the internal jugular vein goes through what hole? Jugular foramen, exactly. And then let's put together what you get with the internal jugular vein together. So here's your internal jugular vein. You can find it by following it out from your skull. Internal jugular vein, right? And then it's going to gather up what you're doing, what you're draining from the outside of the head. That's the external jugular vein. Is that okay? And then this little guy that's running through the transverse foramina is probably the vertebral vein. Yes? And you're going to gather up all of that blood, dump it into the subclavian when you get the head and the arm together, then this is called the brachiocephalic vein. Is that okay? And the two brachiocephalic veins will join to become the what? Superior vena cava. So there's a difference. You have one brachiocephalic artery on what side? Right side, but you have two brachiocephalic veins. Is that good? Okay, so this part that I just did, this last little part is not going to be on the test because we're going to practice that a little bit more and you get to do it in lab. It'll be on your test. Okay, so up into, stop at Roman numeral 3. Okay, and the rest of this is on your test.